Hello. This video is a quick discussion on a comprehensive approach to lower extremity evaluation. What that basically means is that I will be discussing how I evaluate an injury that occurs within the lower extremity, so from the hips down. This video will also discuss gaps within my evaluation, or basically areas that I can improve on to complete a whole evaluation, looking at the entire kinetic chain. To introduce myself first, though, my name is Elena Robinson. I am a licensed and certified athletic trainer and a student within Indiana State University's Doctorate of Athletic Training program. I work as an athletic trainer at a high school in Lafayette, Indiana, as well as being a student. Begin, say somebody were to come up to me, a patient were to come up to me with an injury. This is like my very basic approach when I look at the entire person or patient as a whole. So when they come to me, I first evaluate them from a distance as I prepare to examine the injury. So this could be anything from, kind of how they walk, their gait, to how they carry themselves. Maybe they're guarding the injured area. They could have crutches or a boot or certain things. So I take note of things like that as I prepare to examine the actual injury. Then I focus on the injured area, so the anatomical and physiological limitations they may be having. When I start focusing on the injured area, this is where history comes in, looking at the causes, the mechanism of injuries, asking them what limitations they may be having with their activities of daily living. Then I would assess by actually assessing the area and looking for changes when compared bilaterally, as well as range of motion, strength, and soft tissue neurological testing. So the basics. Then I often will look up and down from the area that is injured. So if it's the knee that is injured, I will look up the kinetic chain towards the thighs and hips area, and maybe as well as the trunk. And then if I look down from the knee, I'm going down the kinetic chain, looking at the feet, ankles, lower legs. So I'm trying to find any correlations with the injury, other possible causes or mechanism of injuries, as well as just any general deficiencies or physiological issues that I may take note of. Then I generally will go to the assessment part of the evaluation, and there I usually make note of emotional or mental limitations with the patient, so we could have that discussion. Exchange the goals, so see what the patient's goals are and give the patient my goals for them, and then make a plan of attack. So this could be anything from immediate referral to immediate treatment, rehabs, etc. So focusing just on the lower extremity, like I mentioned before, when there is an injured area, I tend to evaluate above and below the area of injury. This is for me personally to look for connections or other causes that may be connected to the injury itself. So this is something that should be done for every type of athlete, patient. I really should have included that, as well as every type of injury. However, I do not always include this. There are gaps in my evaluation when looking at an injury, and therefore this leads to gap number 1. So gap number 1 in my evaluation, I've noticed, is looking, kind of expanding the history section, or the questions that I may ask the patient. Some of this includes training errors, so I often don't think of, especially for athletes, the preseason conditioning or certain things they may be doing in their training that could lead me to find the cause of the injury, or as well as help me make changes to their training that could be incorporated within a rehab or whatever is necessary. So I often do not look at training with the athletes that I see. So overall, training errors should be considered along with other factors in running injuries. I focused on running injuries here because I took this comprehensive approach to a more personal level, and as I evaluated my way of evaluating the patients, I did that over this past few weeks, and I've had a lot of running injuries, and so I made this more personable for me. So other factors that could be involved with running injuries in general: shoes, arches, orthotics, years of experience, surfaces that they may be running on, muscle strength training, etc. There's a long list. I obviously focus on training errors, something that I don't think about very often. And this could be something such as increase in mileage or excessive mileage over a week's time. Or you could even break down over a day's time. And then also sudden change in activity. So I think this one relates more to the patients that I've been seeing lately. I have noticed, now that I've evaluated myself, that some of these patients have changed in activity. They'll do hill training, and then they'll do interval workouts the next day, and then they'll do a different type of workout the day after that. So this is just some things to keep in mind for expanding my history section. So gap number 2, this is looking at patella location. So this is an example of how I can improve on my visual assessment. So for a specific example, generalized knee pain, or often sometimes we like to diagnose it as patellofemoral pain syndrome, can be caused by multiple factors. One is patellar maltracking. So this is something that I don't necessarily look at, which is, thankfully, I've caught myself on now, and is something that I should look into more often. Lateral tracking of the patella is a potential cause of patellofemoral pain syndrome. And when you notice the lateral tracking of the patella, this can also lead to looking at other factors such as altered muscle function or muscle length of the surrounding knee stabilizers, especially your quadricep muscles. Looking at also altered kinematics of the hips and feet, and already sort of mentioned quadricep muscle imbalances when it comes to strength. Another article actually discussed, it was a study done on patellar taping, and when the patellar taping was used for lateral tracking patellas, it was noted that it decreased pain in patients with patellofemoral pain syndrome, and it also correlated with improved balance. So this is just something that I should keep in mind when I do more of a visual assessment, specifically around the knee as well. And then gap number 3 for me personally, I once again need to expand my history section and looking at lifting programs. So for lower extremity lifting, the squat is utilized a lot, and there are 2 basic types of squats, the front and the back squat. While both may be effective for muscle utilization, the front squat tends to have less compressive forces on the joints and has less extensor muscle movements, specifically around the lower back. Also, when you look at lifting, specifically for any knee type of bending exercise, looking at knee valgus, so biomechanics during lower extremity lifting is very important. And a specific example is that a knee valgus increases stress on the ACL. So looking at biomechanics could also lead to a higher quality reflection on the injuries that I've seen, and then that could also lead more into a prevention program being put in place as well. So these are my references for the research that I found, but that was a very short, very basic overview of my way of looking at lower extremity injuries, but more so focused on the gaps that I have found. And now that I have been able to reflect on those gaps, I hope to really start incorporating the research that I have found and improving my evaluation skills of the lower extremity. Thank you.